there's orthopedic oncology. I just wanted to briefly talk about what we do, when we operate, the types of resections we do, and then just overview of some common kind of themes with benign bone and soft tissue tumors and malignant bone and soft tissue tumors, some principles of our biopsies, and really what our intraoperative needs are. So I think these are my partners, Rich O'Donnell and Rosie Westrock. So we do quite a wide variety of things. So we really treat adult and pediatric patients with both benign and malignant bone and soft tissue tumors. And these can be extremities, pelvis, spine, sometimes and oftentimes overlapping with some of our colleagues. So sometimes we'll have neurosurgery, thoracic oncology, surgical oncology colleagues helping us, or some of our orthopedic colleagues. And because of this, I think it lends itself to many different surgeries, and I think kind of given the way we book cases, sometimes like a case can get booked that's a 45-minute case the same way as a case that's like a 7-hour case. So sometimes it's really hard to know what the heck it is what we're actually doing that day. So we obviously, like any surgeon, see a lot of patients we don't operate on that don't need surgery. But when we do operate, it's generally if we need to do an open biopsy to make a diagnosis. So if we're not sure what something is and we don't think a needle biopsy is enough. Pathologic fractures, which I didn't talk too much about, but we see a lot of patients with metastatic disease from various cancers, then we'll be treating their pathologic fractures. And then the types of resection, so we'll do something called marginal or intralesional excision of tumors that are benign. And that means we're just, I have a next slide, but just operating inside or right on the tumor. But then for malignant tumors, whether they're bone or soft tissue, we're often doing a wide resection. So we're not just taking the tumor, but we're taking normal tissue outside of it. And those surgeries are generally much more involved because we're resecting more. The other category that you'll see is kind of either revision or lengthening of prostheses, or using these to reconstruct the defects we leave behind. So some segmental prostheses that there are, so in the top right is the compress, which we commonly use for distal femur. Below that's a proximal humerus. So sometimes we still will use stemmed implants as well for older patients or people that we don't think can heal under the compress. So types of resection. So this really dictates oftentimes the length of our surgery is the type of resection that's needed. So something called radical excision or radical resection, which is actually how things are billed, but no one really does that anymore. That's when you excise an entire compartment. So if someone has something in their thigh, you take the entire muscle from the top to the bottom. So basically over the whole length of the femur, for example, if something was in the quad muscle or the thigh muscle. And it's really not done because we don't think it's necessary. We think that what is commonly done is a wide excision. So a wide excision is for all malignant tumors, and this is when we excise normal tissue around the tumor. And because we really don't think malignant tumors are truly encapsulated, so when people say, oh, is the tumor encapsulated? Well, we think there's actually this reactive zone of tissue that's around the tumor that has microscopic cells. So we think if we stay outside of the tumor, we're getting those cells that kind of live outside. So once we're doing a wide excision, that's when we're really taking a rim of muscle around the tumor, we're taking extra bone above and below, and usually those are the surgeries that are lasting a lot longer. But for benign tumors, marginal excisions, where we're just kind of shelling it out, so the lipoma cases or nerve tumors or things where we're just taking the tumor out, those are oftentimes a lot faster because there's an easy plane between the tumor and normal tissue. Or lastly, intralesional. So anytime we're scraping benign things out of bones or curettaging, that's considered intralesional because we're actually inside the tumor and scraping it out and not. So we know that even with that, it's very likely that we're possibly leaving some cells behind because it's not a true wide excision. But we think it's safe because it's a benign tumor, or sometimes that's when we'll use the argon beam to kind of burn the inside of the cavity. But that's really just reserved for benign procedures. And these diagrams are just showing kind of the difference. So for the one on the left, the soft tissue, Intralesional means inside the tumor, marginal is right around the rim, and a wide excision is taking extra tissue around that, and with the bone tumor on the right. Now the exception to wide is we're often sometimes really close to the tumor if it means sparing a really important nerve or vessel. So there are times we definitely get close, but for our malignant resections, we're really actually trying not to get into the tumor. So kind of one thing I want to bring up later, because the common question is, when do we need new instruments for closing? Like the goal of our surgery is never to see tumor for malignant tumors. It's just sometimes it's nice to have clean instruments just in case. So because it's been a long case, there's been a lot of instrumentation. And then on the flip side, for these benign tumors that were intralesional, even though it's benign, sometimes it's also nice to have clean instruments because we're still trying to get rid of the tumor, and we've been inside of it, so we know that there's tumor on all those instruments, and so we like to ask for new things. So there's like huge review courses and things talking about all the different kinds of tumors and things people have, and still to this day we'll take things out and it's like, oh, I haven't heard of that one before. So I didn't want to get too into depth of like all the specific tumors that we treat, but just some overlying kind of concepts. So common benign bone and soft tissue tumors. So the common presentation of these, if they're in the bone, they're usually asymptomatic. They usually have been there for a long time. And common presentations of benign soft tissue tumors is often people just notice a lump. So they can be painful, but oftentimes they're not. And people will think, oh, I just bumped my leg there, and then they'll realize there's an actual mass there. Benign bone tumors, often, probably one of the most common things we see are people that had a knee injury, and then they get an x-ray to evaluate that, and then they realize, oh, there's something abnormal in the bone. So when do we operate on benign bone tumors? So we kind of categorize these in three different categories. So latent is same as basically saying inactive. So these are benign bone tumors that we think, based on imaging and the patient's symptoms, have been there for a long time. They're not growing, they're not changing. The only time we operate on these is if we actually think they're symptomatic. So if we've ruled out every other cause of pain, so occasionally we do operate on these, but most of these patients are just seeing us for follow-up in the office. Benign tumors can also be active though, they can grow. The main difference is if they're benign, they can be locally destructive, but they have no potential to spread elsewhere in the body. So benign tumors can be symptomatic, and they can be problematic, but we know they're not life-threatening. So once they're active and growing, then they can actually cause pain from the surrounding inflammation. If they're destroying so much bone that the bone's actually about to break, generally those are the times we're operating on those. So oftentimes, these are probably more common on the PD side. So like some of these like bone cysts, like aneurysmal bone cysts, something called chondroblastoma, these kind of things we're operating on more often in kids because they do have these active benign tumors. Because if we don't treat them, they'll just keep getting larger until the bone breaks. There is a category of aggressive benign tumor. Giant cell tumor is probably the most common that we see on the adult side, where they'll make a huge hole at the end of the femur, and we will scrape these out intralesionally, but we actually are trying to get rid of the whole tumor, but we don't think we need to be so aggressive as to like remove the whole end of the femur. And so those are probably the most common, where we're scraping it out and then using the argon beam to burn the walls of the cavity and then packing with cement. Those are most common in like 30-year-olds, and so we see a fair amount on the adult side. These are just some x-rays of common benign bone tumors we see in peds. So one thing that's common about all of these is definitely you can see a bony abnormality. So on the top left in the ulnar bone, you can see that there's kind of holes in the bone. I'm sorry, I don't have a pointer. Go up there. And these patients, depending on how big the holes in the bone get, may or may not fracture. But these are easy to see. They're kind of easy to see where normal and abnormal ends and begins. And so that helps us determine even before, like when we see the patient, what this is. So it's not all of these we need a biopsy. Sometimes just on x-ray alone we can tell. So oftentimes once the patient's made it to the OR, they've already seen us, we do a lot of imaging workup, and the imaging workup really helps us get a good differential of what it is that we're treating. So almost everyone for bone tumors has just plain x-rays. Sometimes we'll also get CT scans to really see how thin the bone is. Bone scans can show us how active the tumor is like, generally the bone scan will light up in an area where the bone's trying to heal itself, so it'll light up for a fracture, but it'll also light up if a tumor's active and kind of eroding the bone. We get a lot of MRIs, and that's because how things look on MRI can also help us with the differential and give us an idea, is there a lot of surrounding inflammation, is this an active tumor or is this an inactive? PET scan we'll often get too, just as a kind of fancier way to judge if something's active. Oh, you do have a phone. Awesome. Thanks. So one thing when we're looking at these x-rays is the really question is, what's the bone doing to the tumor and what's the tumor doing to the bone? So here's an x-ray of probably a teenage kid, and you see this, there's a hole in the bone, there's some kind of tumor there that's making a hole, but it's really well defined. There's like this white line that surrounds what we call sclerosis, and that means that the bone's had a lot of time to really wall off that tumor, and that tells us that this is either slow growing or completely inactive. So we consider it a well-defined, it has a sclerotic rim. So when I see an x-ray like this for a kid that comes to see me, I'm like, okay, well this has very benign characteristics. And then there's other things about it. It's seated more on one side of the bone, and this location of the bone is called the metaphysis, where the shaft meets the end of the bone. So all these things actually characterize a certain benign tumor called a non-ossifying fibroma, which generally we don't operate on unless this gets so big that we think the bone's about to fracture. Occasionally you'll see some like gnarly video on the news of some person playing basketball and their bone just breaks, and we're like, oh, they probably had a non-ossifying fibroma just sitting there. So MRIs, what we use the MRIs for, even for benign tumors, here's a side view of the femur, so here's the kneecap, then a femur, and here's this mass inside. But it's really well defined. It's not breaking through the bone. There's not really any surrounding edema or fluid or inflammation. So if someone comes with an MRI of this, I can be like, you know, it's probably benign, it's been there for a long time. If it's growing and the patient's having pain and I really think there's a fracture risk, we would bring them to the OR, but aside from that, we can just watch it. Versus this one, this is a different MRI sequence, but looking straight on at the knee. So here's the end of the femur, and here's the top of the tibia. Here's this lesion here, and all this white, that's all fluid. So that tells us this is a super angry, inflamed bone. This is a kind of tumor called a chondroblastoma that grows at the ends of bones in kids. And we know that has to come out because it's active, it will keep growing, it causes pain, and eventually it will lead to fracture. So it's a lot of what we do, all the planning and like differentials come much prior to the actually going to the OR. So as far as soft tissue tumors, common presentations of soft tissue tumors are a painless lump. So lipomas, which this is probably a lipoma in the back of someone's shoulder, is the most common soft tissue mass that exists. So very common, a lot of different surgeons take them out. There's some dermatologists that will try to take them out in the office. And they're just extra fat that grows. They're usually not symptomatic. Occasionally, if they get large enough, they can be. People commonly get ganglion cysts around their wrists or other joints. That's also very common. You can have painful soft tissue masses, like nerve-related tumors or really vascular tumors can be benign but cause a lot of pain. So here's another thing about a lipoma. Lipomas are fun cases for us because they're generally fairly quick. They come out fairly easy, and they're a nice break to the struggle of our bigger cases. And they can really be diagnosed on MRI alone. So here's a cross-section of someone's thigh. So here's the femur, is this black circle, and the quad muscles in front, hamstrings and back. And here's the mass, and it looks exactly like the subcutaneous fat surrounding it. So when these tumors look the same as subcutaneous fat on all the different MRI sequences, then we're like, hey, you have a lipoma, good news. Like, if it's not bothering you, you don't have to take it out, but if it's bothering you, it can come out. So sarcomas are a different beast. So sarcomas we treat commonly, they're really a tumor that has a mesenchymal origin. So mesenchyme, going back to embryology, most of which I don't remember, basically every kind of soft tissue of sarcoma can arise from. So we have sarcomas of bone, blood vessels, nerves, fat, muscle. All those are different variations. So if you hear, oh, it's a rhabdomyosarcoma, well, that means it's a skeletal muscle origin. Or a liposarcoma is from fat. Or osteosarcoma from bone. So sarcomas are really rare. So when you think about, there's probably about 450,000 new cases of breast cancer diagnosed every year. There's maybe about 10,000 to 12,000 soft tissue sarcomas diagnosed. So they're really less than 1% of all cancers. So even though they're common in our practice, they're very, very rare. And osteosarcomas, which are the most common sarcoma in children, and we see occasionally in adults, there's about 1,500 cases. So actually pretty rare disease. But all of these have to be removed. We do not have any treatment that spares someone surgical excision. And then depending on the kind they are, sometimes if they're responsive to radiation, before or after we take them out, the patient will get radiated. And then sometimes they'll get chemotherapy before or after. If it's spread, then they will definitely get chemotherapy, but especially in adults, not everyone gets chemo. So I like the color for sarcoma is yellow, so that's why this says not all cancer is pink. So malignant bone tumors. So the X-rays before that showed a nice, well-defined kind of hole in the bone. Malignant bone tumors are generally the messy side of tumors. So here's a MRI of a osteosarcoma. So you see all this white inside the bone and this mass. Here's an X-ray where the ends of the bone, the covering, the periosteum is lifting off because it just can't keep up with the growth of this tumor and it's super inflamed. These are generally really painful, whereas benign bone tumors, they can be painful if they're active, but they don't. This is like a different degree of destruction. Here's a picture of a bone scan. So some of these areas should light up, like the sternum, here's the bladder, but this is where the tumor is, so we wouldn't expect there to be uptake there. So we'll use this and some patients get these to see is there any bony destruction elsewhere. So the common malignant bone tumors that we're treating here, osteosarcoma, Ewing sarcoma, chondrosarcoma. If you hear sarcoma, that means we're doing a big surgery. Unless occasionally, like I had a patient who has like a 2 centimeter sarcoma, and that's just really lucky that they found it really early. Also, just to keep it in perspective, so if a patient comes to see us and they're over the age of 50 and they have a bone tumor, much, much more likely it's metastatic disease, multiple myeloma or lymphoma. So because sarcomas are so rare, we do see them. But the vast majority of people that have a bone tumor and are over 50, it's much more likely it's like a lung cancer that's spread. So we do commonly diagnose primary cancers in our office. So someone came and saw me and they had it for a tumor by their tibia and they were 60 and I'm like, this is much more likely metastatic disease. So we got a CAT scan and found a big tumor in their lung. So we really are sometimes diagnosing people's other kind of cancers just if they present in the bone. So just this X-ray, the main thing, you don't see a nice, like, well-defined hole in the bone. It looks, there's definitely dark spots in here, but the point is just to compare the two. This is hard to see where the tumor ends and begins, and this is a sign of a lot of bone destruction and inflammation that would make us think that this is more of a malignant process. Here's some other X-rays, some gross pictures. So here's a bivalve tumor after it's been resected. This is an osteosarcoma growing off the surface of the femur, and here's kind of what on X-ray it looks like. It's growing off the back. Here's some other pictures of where the bone's been destroyed from the tumors. Other things these tumors do is grow outside of the bone. So here's the X-ray of the person's humerus. And then when you look at the cross-section of MRI, this black circle is supposed to be the humerus, but you can see the tumors inside and kind of growing out and invading all the surrounding muscles. So this is causing a lot of pain and problems. So how do these present? Well, pain. They are always painful because of all the destruction and inflammation. So here, looking at this person, they have this swelling in their shoulder, and that's all from the tumor that's actually underneath. Now, just one interesting thing about malignant soft tissue tumors is they're generally not painful. So sometimes we wonder, like, how did this person have this 20 centimeter mass in their thigh and not know? Well, because generally they don't hurt. So whereas like small benign soft tissue masses can hurt, these large soft tissue sarcomas that grow in muscle generally don't hurt at all. And so usually when we find them, they are really big, and people don't even notice until they're like, hey, why are my pants like tighter on one leg than another? And for those of us that wear scrubs, you know, it has to be pretty big before we notice our scrubs getting tight. So sometimes they're misdiagnosed as a hematoma, or which is like bleeding into the thigh, and but it's just very rare that they're actually causing pain. Sometimes if they are causing pain, it's a good thing because it lends itself to finding them. Here's an MRI of a sarcoma. So here's a cross section of the femur. Black circle again is the bone. Quadriceps muscles are in the front, hamstrings in the back. And this is the same, just different sequences. So MRIs, you know, they scan the same area, but they have different sequences they do to kind of tell us characteristics about the mass. So this is called a T1, where the surrounding fat is bright, and here's the mass back here, and on the T2 it's bright. So these look kind of ugly. They're not like like the lipoma is just a smooth white color, all look the same, but these will look very heterogeneous because there's sometimes blood and solid components in them. So when the patient comes to see us and they have this painless mass in an MRI that looks like this, we know that sarcoma is probably most likely. We're getting them set up for a biopsy. Sometimes when these are close to the skin like this, we just do the biopsy in the office because it's way more efficient, obviously, than the whole process that goes into doing the biopsy in the OR. But sometimes it's limited. You know, a needle biopsy has limitations in the amount of tissue, so that's when we'll take someone for an OR biopsy. So the idea of the biopsy is we need to know what something is before we take it out. It happens all the time, but really, like, people shouldn't be taking stuff out if they don't know what it is. And that's when people get into trouble. And there are definitely still plenty of times where people are taking out something without imaging and without a biopsy. Now, not everything needs a biopsy, right? Like, you can tell a lipoma from an MRI, that's fine. I don't get paid to order, you know, imaging and biopsies, but the whole purpose is I need to know what kind of surgery to do. Am I just gonna shell this out because it's benign, or am I gonna spend hours and hours like cutting through muscle and doing, you know, a big wide resection? So there is no harm in ever doing a biopsy. Like, no one's ever gonna fault you for getting a diagnosis first. And some of the patients that show up in our office are people that were like, well, they thought it was this, and then they got in there and realized it wasn't, and then they found out it was a sarcoma. So it does happen, and it, you know, is unfortunate because it can lend itself to further problems. But usually, if there's any question that it's malignant or any concern, we're doing a biopsy. So that could be a core needle biopsy, which is like can be from a 14 to an 18 gauge needle that radiology does with image guidance. So like, if someone has something in their hip socket or really deep, I'll send them for radiology because they can do the biopsy with CT guidance, and it's easier than doing a big open biopsy. The idea, though, is for a cancerous tumor, you want to plan that biopsy to be in line with where you'd make the incision to take out the tumor. So you always need to have a conversation with your radiologist and say, so for example, this is a cross section of the thigh. Here's the femur here. Quad muscle, and they are kind of going straight through your quadriceps tendon, which helps extend your knee, but that's actually like the total wrong thing to do because we don't want to contaminate the quadriceps tendon, which we want to save with potential tumor cells. So generally I would say, no, if I take this out, I'm going to come from the side, so make sure when you're approaching this that your needle's coming from the side. So we have these conversations with radiology. So sometimes it doesn't matter if it's metastatic disease and the tumor's not going to come out and it's just going to be radiated, fine. But for sarcomas, when I know it's going to come out, if radiology is going to do the biopsy, I want to talk to them about where the needle's going to be, so I feel like I'm excising that needle tract at the time of surgery. Sometimes it's enough for diagnosis, sometimes it's not. So then we do the open biopsies. And sometimes you've probably seen us just do a biopsy, and then you've seen us do an open biopsy, and then based on the frozen, take it out. The open, with dependency on the frozen, usually reserved for benign tumors. So if I have a kid, I'm like, hey, based on imaging, I think it's like 95% this. I just want to confirm with the frozen. Or I think it's a metastatic tumor that I can just, in the bone, and I just need to put a rod. That's when we'll do the frozen and say, okay, does it look like this? It does. Okay, we can proceed. But for other stuff, other tumors where people need other treatments first, like osteosarcoma in kids, they go through 12 weeks of chemo. We're just then doing the biopsy. So, in summary, orthopedic oncology, so we have a huge variety of diagnoses, a huge variety of cases. We do a lot of planning, a lot of setup is involved, a lot of things happen before we get to the OR. There's sometimes implants involved, but even despite all that planning, as you know, there's still a lot of day of action. But what do we need to know? I mean, what's helpful to kind of know what we're thinking is, okay, do we know the diagnosis? So most often the answer is yes, unless we're doing a biopsy, but sometimes there's the category of we're going to do a biopsy and a frozen and then proceed. And is it benign or malignant? Because benign versus malignant, generally the benign tumors, soft tissue is a pretty simple setup. And even malignant tumors can have a little bit more of a setup, but when we get to the bone tumors, like a benign tumor setup might just be scraping it out and using the argon and maybe putting a plate, versus the malignant tumors can be huge metal implants. So there's all different categories that kind of lends itself to our setup. And then it says what time of resection, but what I meant is what type. So that'll also say and give you an idea of how long the case is going to be, and then are we going to do a reconstruction? So if it's bone, it won't just be taking out the tumor. Are we just going to put cement in? Are we going to do a plate? And there's not an easy way in our system to clue you into what the plan is. I mean, I can put in the case notes, okay, I need X, Y, Z, but a lot of times that's why we end up needing to have those conversations before, just to get an idea. So, here's a picture of a person with a lipoma. So that looks like a big mass, but it's probably going to be like an hour, because it's going to come right out, and then we're going to close, and it'll be, high five each other and go home. But this is, a big osteosarcoma, so I'm probably going to struggle through dissecting all the vessels and nerves back here, and 6 to 8 hours later just really be wanting to go home. So that really lends itself to the different kinds of surgery. So just these are some things that I kind of thought of off the top of my head, and I wanted to leave plenty of time too for if you guys have questions, comments. So intraoperative needs. So if the tumor's unknown, and we're doing an open biopsy, generally so here's a MRI of probably what looks like a distal femur osteosarcoma. I'm probably going to be doing a tiny incision, trying to just stay in one compartment, so just stay kind of the lateral thigh area, control the bleeding, keep everything really contained, because I know at some point when I go to take out that tumor, I'm going to have to remove my biopsy tract, so I don't want to make my biopsy tract huge and spill tumor all over. We're going to get a frozen because everyone's kind of waiting on the preliminary, the family is, the treating team, so we always get the frozen just to get a preliminary. And generally it's nice, even if it's just a little kidney basin, to just have something to put dirty instruments, because then we know, okay, all those tumor cells are grossly contained to that, and then we can close up and try to keep the contamination low. And sometimes we use fluoro if it's a really small thing that we, sometimes I'll just measure off the MRI and say, okay, I want to go here, and it's 5 centimeters, so then I'll just kind of go for it and don't, need fluoro. But sometimes if it's smaller, we always want to confirm where we're going. So intraoperative needs for benign tumors. So this is something called a chondroblastoma in a kid. So it's a tumor that this has coral in it. This is what coral looks like later, but it created a hole. This was a case where I was like, I'm pretty sure it's chondroblastoma, which is benign. I'm gonna go in, send a frozen. If they confirm, then we'll scrape it out and put coral in. So and I knew it was most likely fitting in that benign tumor category. So this is that intralesional resection. So I was inside the tumor, scraping out the tumor. This is where I'm like, okay, I need curettes, I need the argon beam. Hydrogen peroxide, I don't know if it does anything, but it just makes me feel better, So, other institutions, they have cryo, so we'll freeze the inside. But the idea is we're scraping. There's probably microscopic cells left at the periphery, so that's why we try to torch it just to kill it.
What is your recurrence though for those kind of benign tumors?
I think it's up to 20%.
That's high.
So we follow. I of course have no recurrences, but general population. But we follow these children for probably 3 years just to make sure there's no signs of tumor coming back. It's like the giant cell tumor for adults. Those actually has a reported recurrence of up to 50%. And so we will follow these benign patients for years just to make sure. I think O'Donnell today has a recurrent giant cell tumor, the proximal femur. They're really nasty. I've had them too. They're benign, but can be super aggressive.
So how do you decide into having said about the 50% recurrence? Why don't you just take the whole thing off and reconstruct?
Well, saving a 30-year-old's knee, I think, is important. So like the function of someone that has their knee joint, they can still run and be active, versus once we do a distal femur and resect that bone, those patients never run. They can run to get out of a burning building, but they're limited to low impact activities, probably are almost 100% chance of needing additional surgeries in the future. So we don't take the whole bone unless we have to. Now, some giant cell tumor patients end up with that because they have multiple recurrences and the bone falls apart, but we try to avoid it. Try to save the joint when we can, because the functional difference is like tremendous. And then for benign tumors, the marginal excision, so that's usually the soft tissue tumors, generally very basic dissection tools. Sometimes even with lipomas, like they'll grow right next to the sciatic nerve, so we'll still have some kind of dissection left, but it's not quite like the malignant tumors. So for malignant soft tissue tumors, this is a patient of mine when I was in Michigan that had a big sarcoma growing in his pec muscle. And so this is a wide excision. So people are always like, I want to see a picture of the tumor. And I'm like, well, technically, like, I'm trying to stay outside of the tumor. So you're just seeing the muscle and skin on the outside. But then I'll tell them once pathology cuts it in half, they can see it. But sometimes for these big soft tissue tumors, we have to get other teams involved. So like this person had a prior biopsy. It was super contaminated. So I actually had to resect all that, and then plastics came in and did like a skin graft and stuff. So sometimes we do end up with, for these soft tissue sarcomas, like needing plastics or other things. And generally the clean instruments is just not because I hopefully did not get in the tumor in this case, but microscopically, if I did, then we just have clean stuff to close up. And then for bone, this is a guy that had a big osteosarcoma in his humerus. So I resected it, and then actually this is an allograft bone, and it's secured to his bone with a rod. But these are probably the biggest cases, the ones with all the trays and the implants, whether it's allografts or whatever, or metal, whatever. We're always sending a frozen from where we cut the bone. So the bone cut is planned well in advance, right? I can look at the MRI and measure from the top of the humerus and say, if I cut there, I'm a couple centimeters away from the tumor. So it's not like, we're still going wider than we think we need to be, but we always send the marrow margin just to be on the safe side. And definitely, again, it's not that we necessarily think we got into tumor and it's all contaminated, but it's more just nice to have that like closed. So that is it.
I also like going home at the end of the day, so I think we all do. I promise. Thank